Well, let's start. Good morning, good afternoon, good night from some of you. This is a real pleasure to have the opportunity to connect with all of you through this joint between ASPHO, the American Society of Pediatric Oncology, and SIOP North America. Uh, for ASPHO, we have Dr. Benjamin Watkins from Tulane University and also Nimosuo Osua from Texas Children's Hospital. And from SIOP North America, we have Dr. Jeremy Sloan from St. Jude and myself from the MD Anderson Cancer Center. And this is a real pleasure to have today the opportunity to introduce our speaker, Dr. Guillermo Chantada. We had the opportunity to interact with Guillermo for a couple of decades now. And just to give you a little brief things about Guillermo, he graduated from the University of Buenos Aires in Argentina around 1981. He pursued a couple clinical training in pediatrics and pediatric hematology and oncology at the well-established hospital Garrahan of Buenos Aires, and also he developed a PhD. And in many of the things that he had done, and I have to be a little reduced in terms of what I can mention because he had many things accomplished, was the principal researcher of the National Council of Research in Argentina. He had been well known in terms of the clinical development and translational research in retinoblastoma with multiple conferences around the world. He is the coordinator of the European Retinoblastoma Group, as well as leading an anti-idiotype vaccine effort for neuroblastoma in Latin American protocol. This is part of his interest as well in lymphomas and histiocytosis. He has many hats at this particular moment. He is the scientific director of the Pediatric Hematology and Oncology Service at the Hospital Universitario Australia in Argentina, and also at the Hematology Oncology Service in the Hospital Pereira dos Rosell in Montevideo, Uruguay. In many occasions, whenever that we talk with Guillermo, we have to ask, in which country are you? And you are going to see why. Can we pass the other one, Andele, por favor, please? He's also a leader and board member of the Latin American treatment protocol at the group of the American Latina of Oncologia Pediatrica called Gallup that was well established in Argentina with tremendous efforts and developments. He's member of St. Jude Global Pediatric Medicine Department, and he had been the editor-in-chief for probably more than 10 years, I believe, something around 14 years, if I am correct, for the Oncopedia Cure for Kids portal. So everything regarding Oncopedia has been the development of Guillermo. He was, and I had the opportunity to work very close with him for many years. He's a member of the board, and he has been one of the past presidents of the Latin American Society of Pediatric Oncology. As a matter of fact, part of the fusion between SLAOP and SIOP started when he was president in SLAOP. He's the immediate past president of SIOP, giving the torch in Amsterdam the last month. And also, you can see what I mentioned about where he's located because he is an associate member of the oncology service and head of the outreach program in Pediatric Center Barcelona in the Hospital San Joan de Dios. And through that, he has expanded with a couple of the colleagues in two different venues, more educational venues, and also some very useful things for pediatric oncology. One has been the program Teleo, and the other the global mapping. So he has make many contributions, multiple publications, book chapters, and so on that I don't have too much time to describe, but just to let you know that we are very happy, Guillermo, to have you here, and the forum is yours.
Thank you very much, Cesar. This is such a nice time to share with you, and especially you personal and you, this interaction between SIOP North America and the American Society of Pediatric Hematology and Oncology. I think this is really something that, as SIOP past president, I'd like to see, and I celebrate this kind of activities. So um, the US and Canada are the one of the top members of SIOP, and so it's a great privilege for me to share with you this this presentation. And I'd like to thank you once again for the invitation and for choosing the topic, because I think the topic is very timely. For those who came to SIOP in Amsterdam, you saw like compressed presentation. As I'm going to today, I will have more time to elaborate more because we had the presidential session at SIOP dealing with this, but there were a number of speakers. So now I have all the floor for me. So it is really a privilege. So the topic that Cesar and Jeremy and Ben invited me to share with you is about the challenges and opportunities for research in low and middle income countries. As you saw from Cesar description of my career, even though now I work in a high income country in Spain, but most of my career was developed in a upper middle income country, which is Argentina, and where I really experienced will be a word, probably suffer will be the other word, of how to do research in these settings in where the conditions are not so favorable. And then I will go over what we are doing in PARC program at SIOP, which we hope it is a transformative program to support research in low and middle income countries. So, well, this audience doesn't need this introduction. I usually include this slide about the disparities in survival in childhood cancer. As you see here, the progress that we enjoy in high-income countries where 80% of our children live, we still have a challenge to cure them all. But you see in green that this favorable picture is not equally distributed around the world. And in fact, where most children live in Africa and Asia and parts of Latin America, about 80% of the children in the world live. So we cannot say that childhood cancer is curable right now around the world. It's potentially curable, but so far the survival rate, no, it's not equally distributed around the world. And why is that? I always make the joke that I like to quote Lady Gaga here, where there are a million reasons why this is not happening. It's not that with one activity that we can change the picture, as you know. It's not that if we bring a couple of great people there and they will teach our colleagues in low and middle income countries how to do it, they will change the picture. It's not easy. It's a complex array of systematic issues that limit the possibility of cure childhood cancer in low and middle income countries. Probably number one, I think, at least for me, is insufficient access to high quality care or to any care sometimes. There are many countries around the world that do not provide access for children with cancer. And by that, I mean that families have to pay from their own pocket, or they're directly, they cannot, there is no treatment available for children with cancer. That does not exist in their setting, in their country sometimes. That is, of course, related to universal health coverage. This is a concept that has really evolved, and there are different definitions for that, but the way we think universal health coverage should be is that families don't have to pay anything from their own pocket when they are uninsured, or their health insurance should cover all the treatment without out-of-pocket expenditure for the families, covering chemotherapy, what the hospital costs, and everything related to the treatment of the child. Unfortunately, many governments do not invest in childhood cancer enough to provide their citizens these basic rights, basic human rights. And probably there are other priorities that these governments follow. Also, it's a matter of, it's a challenge also for us to advocate for these governments to cover, to give universal health coverage to children with cancer, with the knowledge that we can turn your country green. You can really cure children with cancer. It's curable if you decide to invest in the treatment of these children. In all these settings where the access of care is not granted, when the access to primary care is usually limited as well, when there are geographical barriers, where there are socioeconomical factors that are determinants for health, we usually see late diagnosis, and late diagnosis in some cancers will mean cure versus not cure. So, for example, retinoblastoma is one of them. Retinoblastoma is highly curable in high-income countries and virtually uncurable in some low-income countries. And why is that? It's not the different biology. It's not that they don't have the treatment. It's that they arrive when the disease has already metastasized to the CNS, and there is no treatment anywhere in the world for that. For other tumors, may be more complicated to determine, especially for ALL or for other leukemias, where there is also an influence of late diagnosis. We see cases with Burkitt's lymphoma, for example, with very advanced disease, with renal failure, tumor lysis, etc., when sometimes a matter of a couple of days really makes the difference. In these settings, also, sometimes there is some sort of universal coverage, but the amount of the number of drugs that you have available is very limited. So sometimes when you make a survey, like we did in global mapping at SIOP, some countries, some members of our community said that in their country there is universal coverage for chemotherapy, but they cover 5 drugs. So it is not, that's not enough. So I think here the global platform that St. Jude is leading with the WHO to provide free high quality chemotherapy drugs based on the essential chemotherapy list from the WHO is really another transformative program that ensures access to the chemotherapy drugs. If you're lucky, if you have access to high quality care, if you have universal health coverage, if your patient is not in an extremely late diagnosis that you can still have an intention to cure, you still have the problem of the higher toxicity of the treatments that are proposed in high-income countries. We are talking about in greater detail later, but this for many tumors, especially hematopoietic tumors, where hematopoietic malignancies, where you need a highly intensive treatment for curing these children. This is barely possible in these settings because sometimes the patients come with other comorbidities like malnutrition. There are other even genetic factors that predispose them to a higher toxicity. There is not state-of-the-art supportive care in many instances. Access to intensive care units is not always possible in all the patients, and we cannot just apply the same treatments. Sometimes, even more paradoxically, sometimes you get there, you could treat the child achieves remission, and then the family can't comply with treatment, even sometimes when there is coverage of all the expenses, because sometimes they live far away, sometimes they lose their job if they stay with the child receiving treatment, or they have other kids to take care of, so it's a very painful decision. It's a very complex problem in low and middle income countries that the treatment compliance is usually a big issue, necessitating a comprehensive approach that some settings are able to provide. And of course, all this last in this list is that there is no investment in research, but uh, there is, as you probably you know or you figure out, that there is a mismatch between the disease burden and the research activities. Uh, Only, first of all, there is a mismatch for children. 10% of all the clinical trials around the world are done in children, only 10%. And of them, only 9% are done in low and middle income countries. And of them, only 1% are done in low income countries. And in pediatric cancer, according to a study that Daniel Moreira led at St. Jude, that will hopefully be published next week, I think, or even this week, most of these studies are in supportive care and not on interventional trials for treatment. But if you see here, this is a WHO graph where you see the runs that are related to countries and regions. So you see here, like the global south is really lacking the grants for research in this is not in pediatric cancer, this is in pediatrics in general. But the question that then comes, probably you may wonder, is that, well, if these are the big problems, do we really need research for childhood cancer in LMIC? And I always said everything, absolutely everything we know about how to cure childhood cancer comes from a research study done sometimes somewhere. So, and as I said before, most of the times you cannot apply this evidence to different settings. So if you can't just follow what has been done in high income countries in your setting, of course that we need research. So, and also, sometimes there are questions about this, especially for when we say, okay, we need to do research in children in a very disadvantaged social situation. So the natural reaction from many people, many colleagues, and sometimes from the public is that, oh no, there is a risk for abuse of these children, or if we take them as subjects of research studies. But at least in my view and many others, probably if we know that research is the best, and we agree on that, and I think we all agree on that, that research is the way of giving a better treatment and a better outcome. That is something that we learn from high income countries. So if that is something that we agreed, what are we doing if we don't give access to research of children in low and middle income countries? Is that we are protecting them? Or is the other way around? Are we denying the right for a better treatment to them? So then this question of do we really need research for cancer in low and middle income countries? Some people will say, is it a luxury? We just apply evidence-based medicine. But evidence-based medicine is based on evidence in high-income countries. We have to, evidence-based medicine is also includes generating evidence, and evidence is setting dependent. So you need to generate it before you apply it. So that's what I always said. That's the like the trap of evidence-based medicine, because most of the evidence, almost all of the evidence, because we saw only 1% of the trials are from low-income countries, so it is usually not applicable. So the answer to this question is that if, for me at least, do we need research in low and middle income countries? Sure we do, at least it's my opinion. Unfortunately, it was not just my opinion, SIOP's opinion, or a few guys' opinion, but fortunately, the WHO, that was really instrumental, because that happened after COVID, where you saw that much of the evidence that were provided at the COVID times, even the vaccination, came from low and middle income countries. So in 2022, the WHO released this document, which is a resolution, which means that has been approved by all the member states to strengthening clinical trials to provide high quality evidence. Look at the title, to provide high quality evidence and improve research quality and coordination around the world. That is not just pediatrics, it's not, of course, it's not pediatric cancer, it's research in general. And that is something that's a new tool that we have now where we in low and middle income countries, our colleagues go to their government saying, okay, you signed this, you accepted that you have to strengthen your clinical trial capacity. And of course, if it is the WHO saying that, it's really very impactful and more convincing, of course, that it's just a community of one of disease. And it's interesting because you see here that they mentioned very specifically preventing unpowered, poorly designed clinical trials to avoid the participation of children in clinical studies that are poorly designed or underpowered. That is of course uh, something that we don't want, and that is what we should protect our children to. But we should give access to the ones that are really powered to show a difference and are well designed. So the issue of quality here is really important and essential. So a few examples of why we need that. When my preferred tumor, the tumor I work mostly in my career is retinoblastoma. So you see here, we did a study back in 2010 where we showed that doing a systematic review of, I think there were more than 13,000 papers, including the great literature, because in many languages, because much of the literature is not reporting data from low and middle income countries. We were able to show that there is a survival gap in retinoblastoma, and that was dependent mostly on the Human Development Index of these countries and not other factor. Later, the group by Didi Fabian did a great job because he was able to prove this in a prospective fashion, as you see here in the left-hand side of the slide, where you see here the survival rate in green of retinoblastoma in high-income countries, almost touching 100%. And you see here in low-income countries, where it is about 50%. And that is probably an overestimate because we are sure that the results are even worse than that. So there is a big survival gap, which is affected by social determinants of health. And this survival gap also is related to a different pattern of events. Of course, it's not just that they have more events. It means that the events are different. So you see here, and that also influence critically the treatments that we give. So you see here in high income countries, you see the description of the events that could have a child with retinoblastoma in this setting. Most of the events are secondary malignancy that occur 20, 30, 40 years later. Very few children die of toxic death. Very few of them died of retinoblastoma, and almost none abandoned treatment. You see here so all the treatments are based because you have survival for granted. So now all the treatments in high income countries are based on reducing the major cause of death, which is second malignancies, which are second malignancies. So that's why we focus on intraarterial chemotherapy, we focus on avoiding radiation. These are the main objectives. But if you're here in a low income country, you don't have second malignancies because probably most of our patients are already dead. They don't have time to have a second malignancy. So your problems are different. Abandonment is about 40%. So children that you were lucky, they were diagnosed early, they were in intraocular stage, and then you lose that child to follow up the family abandoned treatment, and they come back with extraocular disease and die. Sometimes they apply the same treatments as we do in high-income countries, but they have like up to 5% or sometimes 10% toxic mortality rate of a chemotherapy protocol, which is based on standard dose of carboplatin, etoposide, and vincristine. 5% of them will die of fever and neutropenia. So the way they have to improve their outcome is completely different. That's why it's, the research in high-income countries will never provide answers to this situation because the events are completely different. The same in Burkitt's lymphoma. We did this study with Scott Howard a few years ago. That analysis showing that it's a very quite already it's a bit old, this slide, because probably it is in the pre-rituximab era. So the results are now almost touching 100% in high-income countries in Burkitt's lymphoma. And the few children that don't make it, most of them is because they have resistant disease, even for high intensive treatment, and then they die. And very few of them die because of toxic treatment-related mortality, and almost no child is not diagnosed. But you see here, even in upper middle income countries, the situation is different. We have the treatment-related mortality starts to appear. The patients don't tolerate so well the doses of very intensive systemic chemotherapy. And in low-income countries, you see here again abandonment of treatment, again for a curable tumor. What would happen if we just give the same treatment like they are giving in high-income countries, the BFM, the international group? What happens if we give it to this population? So what we will see is that the survival rate will probably not improve as much because we will have more cases of treatment-related mortality, and we need to adjust the intensity of treatment. That was shown by several groups in Central America, in South America, in Russia, in India, where if you reduce the dose and add rituximab, for example, to the induction protocol, the results are going to be better, even when reducing the doses of methotrexate in the induction. The same was seen by the BFM group for ALL. This is the paper, a great paper, a seminal paper published a couple of years ago in JCO, where you see the results. These are upper middle income countries. So you see here that the also in a paper from other countries in South America, you see that deaths in complete remissions and early deaths are nearly totaling at 10% of all the population. And if you see in the high risk group of the BFM, you see here that death in complete remission is really 11%. Also here in upper middle income countries. So the way we think as pediatric oncologists that when a child is high risk, we have to give an intensive chemotherapy to cure them, that is challenged in low and middle income countries, even in upper middle income countries, because as we saw in Burkitt's lymphoma, sometimes intensification is not the answer. Sometimes using immunotherapy to be able to reduce the intensity of the treatment on the induction will probably save more lives. So we're very encouraged and enthusiastic by the possibility of using blinatumomab in these cases in ALL. But okay, I hope I have convinced you that we need research in low and middle income countries, but which are the limitations? Again, one of them is conceptual. Many people still think that we shouldn't do research. We should have even hospital administrations, IRBs, regulatory offices. They still think that we don't need research. Of course, there are financial limitations, and that is what we are going to deal with at SIOP. Also, childhood cancer is rare, Some countries have big populations, but some countries don't. And the limitations on sharing international data in low and middle income countries is really big. There is a study we did a couple of years ago in 20 centers in Latin America about lymphoblastic lymphoma with anonymized data. 6 of the 20 centers did not approve the protocol. Anonymized data, not even not subject to approval for IRB in the US. So it is very difficult to share data internationally in low and middle income countries. There is also a risk aversion by hospital administrators, by the regulatory agencies, and especially by the IRBs. Some of the centers that did not approve that lymphoblastic lymphoma retrospective anonymized study asked for a reconsent to the families. That doesn't make any sense for an anonymous study that will only, it's a very low risk, and 40% were dead. So this is really, IRBs are not helping in most of the times. They are usually employing the high standards they have for example, for a protocol that will is performed for drug registration, a new drug registration. They are applying that methodology for low risk studies, which makes them really unaffordable and impossible to comply. And also the strategy of the pharmaceutical industry. And we think that uh, as the events are different, as I show with rituximab in low-income countries, as the events are different, they need a different strategy, because sometimes these approvals by the FDA of the EMA, they are not possible, even in upper middle income countries. A typical example is naxitamab. We are, we are living what I call the on-label paradox. During decades, we complained that our drugs were not approved, and we were only using drugs off-label. And we were taking from the adults, and then we applied to children, and we're all off-label. Now we have labeled drugs, like naxitamab for high-risk neuroblastoma. But the label is for relapse and refractory high-risk neuroblastoma. That doesn't make any sense for low and middle income countries, because we want to use it in first line. We are not going to prioritize a €500,000 treatment for a child with a relapse and refractory when we don't have it available in the first line. So we need to work together and establish a dialogue, as we are having at SIOP very constructively with groups like Servier, like Amgen, like even YMAPs and come together with our scientific community to discuss with the regulatory offices in low-income countries. And then sometimes these approvals are called global, and that is really not global for me. I think it's not including the global south, at least. And the reason is like this. You see, this slide was done by our co-chair of the Global Health Network, Jack Van Head, and you see here that why we need to put a different place for anti-GD2 treatments in low and middle income countries. For example, even in well-resourced upper middle income countries in South America, the toxic mortality rate, the treatment-related mortality rate of autologous stem cell transplant for neuroblastoma is about 8 to 10%. So probably the way we should use these antibodies is not to use transplant and to replace transplant with antibodies. But that need pragmatic studies, that need the work of cooperative groups, that need persuasion to the IRBs, that needs also a different way of approaching we as practitioners, our patients, because we sometimes think we should try to give the patient the best. Always we think that. And the best, and sometimes we think this is how a patient will be treated at MD Anderson, at Memorial, at Princess Máxima. But if you are in a country that your situation is different, this is not the best. The best is to do a research study to find out which is the best way. Again, the example of rituximab, you see here many publications from Russia, Argentina, India, where rituximab plus reduced intensity chemotherapy achieved the best results. Not rituximab plus intensive chemotherapy. And sorry for the slide in Spanish, but this is just to show that this change can have an impact in public health. In Argentina, we have, thanks to the great work of Florencia Moreno, we have a national registry. So at the national registry, we see all the patients. And this is, I hope you see my pointer. This is where we used the unmodified BFM protocols. What do you see here? That this is our mortality in the first year. These are cases that are dying about treatment-related mortality, tumor lysis, etc. We were applying very high dose methotrexate. All we can do is to reach for 65% survival rate, applying exactly evidence-based medicine, the exact BFM 95 protocol. Then we introduced rituximab, and then that was in 2007, and then we also at the same time reduced the dose from methotrexate and the shortage and the duration of the infusion. That was the only thing we did. You see here that we went from, well, only with that change, from 65 to 83%, almost 84% survival rate all over the country, with reducing the dose of methotrexate. That is absolutely counterintuitive for someone working in a income country. I see that the difference is here. It's in the toxic deaths. These are registered data. We don't have exactly accurate data, but a child with Burkitt's that dies of treatment-related mortality. So, what is SIOP doing? So, why this challenge is because we are this is an old slide. We are more than more than 4,000 in more than 130 countries. So everywhere SIOP is really a global society. The only global society for pediatric oncology with showing out from SIOP. And this slide is a bit old, but now we have also here from Mexico. to Argentina and Chile. The and needs with no funding in the Mediterranean, Saharan Africa, INFOP in India, and GFOP also in Francophone Africa, and it recently created AFOP cooperative group in Asia, so in Southeast Asia, led by Japan. And thanks to support for Foundation S and also career awards by Nikon Chung family, for example, that who give very important career awards to try to train the new generations of researchers in low and middle income countries. We were able to launch so far 2 rounds of grants. We hit the €1 million mark last month. So it is still not a huge amount of money for North American standards, but that is compared to zero. And that's really is the difference between being sustainable or not for these cooperative groups. So we are very proud at SIOP of this program, and SIOP is not just giving money to these cooperative groups. SIOP also in part support these cooperative groups in issues of prioritization of the research projects that they undertake. We provide education and advocacy activities, as I mentioned before. We also strengthen these networks to come up together, for example, for some research program, and created this consortia of excellence. You see the number of patients that we could be treating around the world is really high. And of course, SIOP is always a convening place. We are the conveners for these groups. We host them, we coordinate their efforts whenever we can. And SIOP likes this multi-stakeholder proposal where parental groups are very much involved. They are the ones that work with us in setting up the priorities. They are the ones that work with us in the advocacy. They help us with the support, bringing additional funding to these cooperative groups. So CCI is very much involved. They have a seat in the PARC committee where they have the people with lived experience voice, which is really important. Again, we need to be working with IRBs really to try to have more expedite approvals, to go for a less risk aversion scenario, more coordination. If a study is approved in Argentina, should be approved in Brazil, probably we have the same reality. We don't need to go over again and don't do everything again. If a study is a continental one, that should be really fast track for the approvals, which is really a big challenge as the data sharing, as I said. And in the governments, again, to try to have them support the work that these groups are doing, pragmatic clinical trials, and then use this data for their, not but for the approval of a drug, but for funding, for example, rituximab in the treatment of Burkitt's lymphoma. To support us with possibilities for data sharing, also customs, bringing specimens, providing some tax exceptions to some critical reactant, like for example, those for MECAN amplification detection that will even add significant costs to this determination. Of course, the drug approvals and the reimbursement for the ones that have insurance. And of course, we work also with the pharma. We need to rethink together their marketing strategy in lower middle income countries. And hopefully, as has been done by Act for Children, for example, which Scott Howard is working very close there to provide access for example, in that case, for CAL asparaginase to countries that the drug is not available, and be able to at the same time collect information and do research for this. And with that, I finished. I think we leave us 10 minutes for discussion. I think I was quite on time, and I said it already 15, but it were about 10. So thank you very much again, and I'm looking forward for questions.
Well, thank you, Guillermo. That was a absolutely wonderful talk, and I think you provide a really convincing argument. Not that this group needed much convincing, but about the importance of research in low middle income countries. And just congratulations on everything you've been able to accomplish. Like, it's just really inspiring to see the impact that you've made, and SIOP has made in global pediatric cancer outcomes. A lot of work still to be done, obviously, but just a great
Yeah.
off point.
Thank you
So
very much.
absolutely. And so now opens our Q&A session. So feel free to either raise your hand or to type into the chat if you have specific questions. And so while we wait for people to put into the chat, I did have one question that came up, kind of looking at one of your earlier slides. You had that bar graph looking at retinoblastoma, and you showed going from high income countries to low income countries, the abandonment rate went from, 1 to 2% to 40%. And so I think we've seen that in some of our studies we've done too. And I think that's a real challenge. Also, when you increase intensity, you tend to get more abandonment too. But ways to address abandonment, because it seems to be such an issue, especially in those low income countries.
Yeah, no, great point, man. And I think that first, I also think that it's also a narrative issue because we are uh, we are much better in communicating late diagnosis than abandonment as a community. And probably for childhood cancer, at least in many tumors, probably abandonment, dealing with abandonment could be more cost effective because we really we are not that I'm not saying that early diagnosis is not important, but I'm saying that probably we are not advocating so much uh, programs for reducing abandonment, which could be really very instrumental. We have one very creative program that we are funding at with Foundation S at Park that is led by Trine Israels in Sub-Saharan Africa that he provides unrestricted and financial support to the families. So what this program gives is some money that the families can decide how to spend. And usually they spend on transportation and lodging, etc. That's that is really innovative because the premise there is that they know better than we how to spend the money, and they want the same as us. They want the child to be cured. And she presented a few preliminary results in SIOP, and it's working really well. There is an issue with scale, of course, because but still, as a proof of concept, this is really something very innovative that we are supporting. And also, of course, the work that has been done especially in Central America by the AHOPCA group, where they identify the families that are at high risk of abandonment and approach them with a psychosocial team, and they provide housing, for example. Another big instrument for reducing abandonment is what CCI is working with Foundation S with the Home Away from Home program, where they provide free housing. Sometimes they build a house for parents. That is also a very impactful program that we are supporting at SIOP. So, but still, even with that, you can reduce, of course, like we saw, for example, in another thing that the AHOPCA group did in retinoblastoma was to use preoperative chemotherapy just to make sure the families have time to accept the nucleation and don't go back to their provinces. That reduced from 16% to 4% the abandonment rate. So it's still not zero, but that was able to cure 12% of the children because these children with no new treatment, no new drug, just having more time to approach them and to make it more acceptable for them. So it's a there are multiple possibilities for working on that. But first of all, I think we should advocate better.
No, absolutely. No, great points. All right, we got a couple of questions here in the Q&A. So Sergio says, thank you for such a great talk. Greetings from Mexico. We do have the challenge of abandonment and the continuity of diverse modalities of treatment, such as timing and tertiary care, surgery, and radiotherapy. So great comment there from Sergio. Good point.
Yeah, thank you, sir. Yes, and also looking for shorter treatments and less invasive treatments is also something that we look for, right?
Yeah. And then Mine says, thank you for this nice presentation. She's from Tunisia. We usually use SIOP protocols in our practice, but how could we share our results? So I think that's a question about how to get the results of their protocols out there. And then 2, how about molecular sampling? Could we participate in international collaboration? And finally, the challenge for us is refractory and reloaded forms. Could we create a platform to register this form for collaboration?
Well, yeah, thanks for this question. We discussed at the very beginning of the PARC program, if I think that was a suggestion by Greg Riemann, who is someone that I admire very much. And Greg had that idea that one of the aims of PARC could be to create a worldwide database for research in low and middle income countries. That was pretty not easy for our donors because of the risk of having so much data in our hands and supported by them. So we finally didn't do it, and each group has its own data capture system, which I think what Greg was suggesting was the perfect scenario. I think that would be great. That if we have done that when he suggested, we wouldn't now be having like 20,000 patients already. But unfortunately, and again, this is because of the data of protection issues that is so limiting our progress, and we should try to find a way of making it not safe for the patients, so the data that we share is safe, and also be possible to cooperate. I think the work that is being done by Sam Fogelbaum is really important here, and we try to, for the groups, to try to have the data in a way they could then collaborate with Sam's project, but it needs another step. So we hope we can get there. So it's a great question. And the second question about molecular diagnosis is also a challenge, because for example, there is in Brazil, led by Sidney Eppelman, he has a facility for next generation sequencing for brain tumors, which is free for all the patients from Brazil and free for patients in Latin America that could send the specimens. The problem is to send the specimens, because it's the country doesn't allow to send them away. The Brazil is putting problems to receive it. So these are the barriers that I think we need to be more convincing to try to reduce for our children.
And also Jennifer made a really good point here about sharing your results, getting that information out on how your patients are doing, is to present those at the SIOP Africa conferences. So I think it's a great platform.
Yeah. Oh yeah. Absolutely. Yeah. That's why SIOP is the convener for these activities.
Yeah. And then another question from Chachawan. Working within this space, we are faced with many challenges at the local level. One example is with data sharing. I understand that organizations such as St. Jude are trying to address this issue. Is there any advice you may have in regard to working with local authorities?
Yeah, that's a very important point as well. And again, I think what St. Jude is proposing with St. Jude Cares, for example, is great, because you can have a registry data very well kept and curated, and but some governments will not accept that you provide your data to a database in the US. That is, I always wonder the other way around. Suppose that if you ask a US institution to share the data with an institution in Africa or in Latin America, probably they will say no as well. So this is really a limited, again, one of the limitations, and most of the countries will prefer their local database, but then they don't provide a local platform for that. So I think if you have the possibility that your government will support uploading the data to the St. Jude platforms, that is wonderful, because it is really, really great. Also, Scott Howard is working in with Resonance for some projects like Act for Children. So there are platforms. I think sometimes the permissions are and the GDPR laws are becoming more complicated with time.
And we're about to come to a close here, but I do want to kind of point out, Abdul Wahab made a point that they missed the first part, and we're wanting to get access to the PowerPoint. This is being recorded and will be available on other platforms. And so there will be opportunities for you to review this talk later. So that's a great point. And so it is just past the time. Oh, and then Anelia put in there, we will have the recording of the session published on the SIOP ASPHO YouTube channel soon. So lots of opportunities to watch again. And so with that, we'll close out. Cesar, do you want to give us some parting words?
No, thank you very much, Guillermo, and thank you, Benjamin, and Anelia, and all the SIOP groups, and all the participants, all the comments, Jennifer. We hope so that we can strengthen the interaction with SIOP Africa, that is doing a fantastic job in terms of development of many of these projects. And thank you very much. And you can see for the question and answer, literally, there was really global approach. Many countries in different continents, at least I count quickly 4 continents joined to listen Guillermo and this type of conference. And I think that from the SIOP North America and ASPHO, we are really grateful for your participation, your collaboration, and definitely we continue this effort. And as Guillermo say, we try to strengthen the interaction with the continental branches that we had in SIOP. And I think that ASPHO is a very important element to join, because there are a lot of common things with the special interest group. So we hope so to see you in the near future. Just to remind you, the next year we will be in San Antonio for the SIOP. Hope so that we can see a lot of you guys around here, so we can show a little bit around. And we continue with these meetings 2 or 3 times per year in the junction ASPHO SIOP North America. Thank you, Guillermo, and definitely it's always a pleasure to see you and to learn from you. And I agree with Benjamin, all the fantastic things that you have done for SLAUP, SIOP, and now the rest is coming. Thank you. Have a good day.
Thank you very much, Cesar. Thank you.
Okay.
Bye.